What I'd like for you to do is to get a piece of paper and just write down what you think the answer is. Like we're taking a test instead of just kind of spitballing. Write down your answers. We'll do them one at a time. Or we can rather just answer them all and then go back through them. Not sure. Or we can do them one at a time.
I'd rather do one.
Alright. So write down your answer as we go. What you think the answer is, and we'll see how you do.
Thank you. You're so nice.
It may have a couple on there, but
Would you like my middle school math going on here?
It's all right.
Stir me a boat.
I like it.
Yeah.
Okay. So question number 1. A gravid woman is admitted to the labor and delivery unit with vaginal bleeding. To differentiate between placenta previa and placental abruption, the nurse should assess for, don't pick y'all's answer, just write down what you think the answer is. Everybody got your answer? All right, so let's move on to number 2, and then we'll go back to these 2. Number 2, what effect does epidural placement have on the labor and delivery process? Select all that apply. Choose as many as you believe to be true. All right, everybody done? All right, let's go through these first 2. So, what is the answer to this question?
A.
Excellent. Presence of abdominal pain. Blood pressure is irrelevant in determining which one it is. It's not the quantity of vaginal bleeding. If I said dark red versus bright red, you might say that, but quantity is not really relevant. Fetal position is completely irrelevant. So the only thing that would help you differentiate would be, is the patient having pain or not? She's having bleeding. Is she feeling any pain? Good. All right. What effect does epidural placement have on the labor and delivery process?
A, B,
A, B,
A, B, and C. A is correct. It is likely to give the patient significant pain relief. B, it's likely to cause maternal hypotension, very likely. Those of you guys who've been on OB have probably seen that in action, whether a C-section or a laboring patient. You've seen the patient's blood pressure drop. C, it may slow down the laboring process, absolutely true. D is not true. It does not cause maternal tachycardia. So that is not a concern. Very, very good. All right. Number 3. When admitting a woman in the 3rd trimester with a complaint of vaginal bleeding, what is the priority nursing intervention? Priority nursing intervention. Those of you guys have any clue yesterday, we talked about this very question. Everybody got your answer? Okay. Go ahead. No? We'll just do 2 at a time and then we'll come back. So we'll do number 4. A nurse is caring for a patient who has a complete placenta previa. The nurse is aware that this condition places the patient at risk for which condition? Okay. So let's go back to number 3. When admitting a woman in the 3rd trimester with a complaint of vaginal bleeding, what is the priority nursing intervention?
C.
Very good. Obtain fetal heart rate and obtain vital signs. All those answers are correct. There's not one wrong answer there as far as something being true that we would do. We would call the doctor. We would initiate pad counts. We do want an H&H. But if I say to you, I'm only going to let you do one thing. I know you want to do all of them, but you can only do one. Which one do you not want to walk out that room without doing? I've got to know what my mom's doing as far as vital signs, and I've got to know about my baby's heartbeat. That tells me if my mom's stable or unstable. If she's stable, I've got some time to figure some things out. If she's unstable, I've got to act much more quickly. I could have had other choices up there like start an IV or get an ultrasound, but still, ABCs, vital signs. And for fetal heart rate, that's the baby's vital sign, the only vital sign we can get on a baby. So that's your best, highest priority there. Everybody get that? Okay. Number 4, nurse caring for a patient has complete previa, so that places the patient at risk for which condition? Placenta accreta. Remember what a placenta accreta is. A placenta accreta happens when the placenta, instead of being attached to the uterine wall and peeling off, like an orange peel off of an orange, that's what should happen, it's growing, it almost gets roots, and starts to grow into the uterine wall like this. If this is the uterine wall, it starts to grow into it. And you literally can't get the placenta out without tearing off chunks of the uterus. If you tear off a chunk of the uterus, the patient's going to bleed to death very quickly. So when you have a placenta accreta, if you don't know in advance, they may know in advance because they've seen it on ultrasound. If they don't know it in advance, they'll know it immediately in the C-section. So this patient's having a C-section, right? Because she had a complete placenta previa. So she's for sure having a C-section. When they try to manually remove the placenta, they will find that it won't come off. And there's really only one treatment for that, and that is what?
Hysterectomy.
A hysterectomy, yes. You cannot pull the placenta off. Can't leave the placenta in there. It has to come out, and it won't come off because it's dug in and attached to the uterine wall. So placenta previa puts the patient at risk of a placenta accreta. Okay. And the reason is the placenta is not usually down over that lower uterine segment. The placenta is usually here, on this side of the uterus, this side, top, here, but it's not usually or supposed to be down low. And that lower uterine segment is kind of rough in texture compared to the rest of the uterus, which is more smooth. So it kind of just grows into it.
Would anemia also be some risk because of the bleeding? You said like a woman with placenta.
Oh, okay. Yeah, it does. Okay, that's a good question. There's just where yes, I would say yes. If you ask me that on a test question, I'll have to think about that because a complete placenta previa, in and of itself, if it's not bleeding, it wouldn't. But anytime you have bleeding associated with it, and you usually do, the patient would become very acute. So yes, that probably is not a good answer. But maybe I took it off. These were all test questions that I've taken off because they would become anemic. But as far as what would develop from a placenta previa, accreta is what would develop. But I'm glad you asked that because yeah, I would have a hard time with a test if you said that because it is true. I mean, I may have to think about giving you credit for that. All right, let's do number 5 and number. In counseling the pregnant patient about diabetic screening, the nurse explains that which choice is one of the primary complications of untreated or improperly managed gestational diabetes. Untreated or improperly managed gestational diabetes leads to what? So before we go to the next question, since it's already done, see how I really didn't mean to do that, but I kind of took the question and just put it down into a matter of like 4 or 5 words. When you do a test, if you're answering test questions, you need to try to do that. You need to say, how can I break this down to the basics? What's it asking me? What it's asking me is gestational diabetes can lead to what? Instead of all those words, really that's all it's saying. What does gestational diabetes that's not managed properly lead to? So try to take all the words in the sentence and cut it down to 4 or 5 words and say, what's the question asking? If you have to, write it down on your paper. Write those 4 or 5 words down in your paper. If there's a keyword, and if I would say if the keyword in this, I would say the keyword is untreated or improperly managed. That's the key. Bad, poorly, or untreated gestational diabetes leads to what? Okay, so the correct answer is what?
D.
D.
The answer is D. So let's discuss that. All right. Diabetes, it does not resolve after pregnancy. In gestational diabetes, does it resolve after pregnancy?
Yes.
Always, 100% of the time. They could be at risk for type 2 diabetes later in life, but it will resolve after pregnancy, no matter how poorly managed they are. It's going to go away. Maternal hypoglycemia. We don't worry about a mom's blood sugar dropping necessarily if it's not managed. It's more likely to be high than it is to be low. So maternal hypoglycemia is not what we think of. Fetal malformations comes from what type of diabetes? Type 1 or 2, pre-existing diabetes, right? In order to have a fetal malformation, you must have diabetes while the organs are forming, which means you must have diabetes in the first 8 to 10 weeks of pregnancy. Do you have gestational diabetes in the first 8 to 10 weeks of pregnancy? No. We don't even test for it until 16 weeks, and most of the time it's not discovered until the second check at 28 weeks. So if you have any question that deals with fetal malformations, it must be type 1 or type 2. That's the only diabetes that we have that's pre-existing, or pre-gestational. And this is where students always get tripped up. They always miss these questions because they get mixed up between type 1 and type 2 issues and gestational diabetic issues. Remember that your type 1 and type 2 are at conception that you have that. During fetal development, you have that. Gestational, until you're later in the pregnancy, you don't have it. So it can't cause a problem early in pregnancy if it doesn't exist, right? All right, we'll do 6 and 7. Number 6, when caring for a pregnant patient with a cardiac disorder, it's imperative that the nurse monitor the patient for signs of cardiac decompensation. Signs of cardiac decompensation in the pregnant patient would include the following. Just write down your answer. Ready to move on to number 7? Okay. A patient's 42 years old, pregnant, and has been diagnosed with gestational diabetes. The patient expresses concern as to how this will affect her growing baby. Which will be the most appropriate nursing diagnosis for this patient? Are you ready to do these two? Okay. Number 6, the correct answer should be what?
B.
B is the correct answer. Very good. So there's a whole list of signs and symptoms of cardiac decompensation on your PowerPoint. And they all look like symptoms of what?
CHF.
CHF. It looks just like CHF. So basically what we're talking about is the inability to maintain cardiac output. And that's what CHF looks like. That's what cardiac decompensation looks like. So dyspnea, blood crackles, weak irregular heart rate. So you certainly don't have a regular heart rate rhythm. You don't have hypertension and tachycardia. There's other things. Increased urinary output, dry cough. The only combination of symptoms that are all correct is B. Good. All right. Number 7, the correct answer is what?
C.
Is it?
A.
Correct answer is A. So let's talk about why. All right. The patient expresses concern as to she's got 42, pregnant, has been diagnosed with gestational diabetes. She expresses concern as to how this will affect her growing baby, which would be the most appropriate nursing diagnosis for this patient. So the most appropriate thing is she's expressing to you something that she has a knowledge deficit. She needs you to tell her what she's asking. Knowledge deficit related to antepartum blood sugar deviations and its effect on the fetus. So risk of hyperglycemia related to non-adherence to prescribed diet. That's not right. Where does it say she's not adhering to her diet? Nowhere. It doesn't tell you that. So that is not the answer. Knowledge deficit related to insulin administration. Who says she's on insulin? Does it say that? No. So you can't pick that one. Risk of fetal macrosomia related to hyperglycemia. While that can happen, we don't know that she is hyperglycemic, but the better answer is she asked a question that she doesn't know. The best answer is a knowledge deficit. She wants to know what happens when, how it's gonna affect her baby, the fact that she has diabetes. While this might happen, it really kind of is encompassed in this, and this is what answers the question that the patient asked, right? That makes sense now?
Mhm.
Okay. So, while this is not a bad answer, because you are going to talk about fetal macrosomia if the blood sugar is elevated, this really answers the question. All right. While caring for a patient with preeclampsia, the nurse notes the patient's last two blood pressures have been 162/105 and 160/100. The nurse should be prepared to administer which medication for control of the patient's blood pressure. Number 9. What impact is epidural placement during labor likely to have on the labor and delivery process? No, it's a different question. Select all that apply. I was thinking of the same question. What impact is the epidural placement during labor likely to have on the labor and delivery process? Select all that apply. Since this was already shown, let's do this one too, and then we'll go back through these 3. When a pregnant woman is diagnosed with severe preeclampsia, a magnesium sulfate infusion is indicated for what reason? Diagnosed with preeclampsia, a mag sulfate infusion is indicated for what reason? Why do we give mag sulfate for preeclampsia? Okay, everybody ready? All right. Number 8, what is the correct answer? Good. Okay, so the patient's got significantly high blood pressures. I actually think, I think the reason I took this off is because, I can look it on, but the blood pressure of 160/100, I think the number's like 160/105. So I don't want you to get thrown off by that. It's still a very high blood pressure. And, with the first one especially, 162/105, you would be thinking that you needed to treat their blood pressure. So we're not going to give mag sulfate to treat the blood pressure, right? That's not what it's for, correct? It's not to treat the blood pressure, although it might have a side effect of lowering it. That's not what it's for. We're not going to give Aldomet because Aldomet's given for what reason? Why do we give Aldomet? Who would be the patient who would probably get Aldomet? Remember? Aldomet is a PO, blood pressure medication that's given to replace someone's chronic hypertensive drug. Let's say they're on a chronic hypertensive drug and they find out they're pregnant and they need something safe during pregnancy. So it's for somebody who needs, PO everyday blood pressure medication that's safe during pregnancy. And Aldomet is what's safe. That's what we give Aldomet. So you find out you're pregnant and you're on whatever for your blood pressure, and you can't take that during pregnancy, they would switch you to something like Aldomet. Valium, obviously, is not given for blood pressure, so we wouldn't give that. So that leaves Presaline. What would be the other drug that we might use besides hydralazine or Presaline? What's the other one? Is it Labetalol? Yes, those are the 2. Physician preference. They both work about the same. Good. All right. Number 9, the correct answers are what? B, C, and D. All 3 of them. It's not going to cause hypertension, that's for sure, right? So we're not going to pick that one. Will it increase the pushing stage, second stage? For sure. It will give the patient significant pain relief, yes. But it also will slow down their labor too. Remember, especially if we give it too early, it will slow down your labor. It may stop your labor. Why does everybody end up on Pitocin? Because they give them epidural at 1 centimeter or 2 centimeters. So we have to put them on Pitocin to speed them back up. So this says it may increase the length of the active phase of the first stage. That is true, but it will lengthen the whole first stage. If they're on Pitocin and they get it, very early at all, it stalls out labor notoriously. And also increases the length of the pushing stage, the second stage, because they can't feel to push effectively. So B, C, and D are all correct. Don't be afraid to pick 3 answers. It's okay. If you think 3 answers are right, pick 3 answers. You really want to avoid getting hung up on, oh, how many should I pick? The last time I picked 2, so I better pick 3 this time. That's like voodoo. That is not how you pick your answers. You pick them on what you know, not based on what you think you did the last time, or what is she thinking, or, Number 10 and 11. Now, there may be a couple of questions in here that are from chapter 9. That's okay. It's not going to be on the test, but it's not going to hurt us. All right, number 10. When a pregnant woman is diagnosed with severe preeclampsia, a magnesium sulfate infusion is indicated for what reason? You should all get this right. Okay, number 11. This is from chapter 9, so this technically was not testing material, but that's okay. A woman whose BMI is 29 should be advised to gain how much weight during her pregnancy. So, BMI 29. Okay, number 10, what's the correct answer? It's C. Hopefully I already got that right. We give magnesium sulfate to our preeclamptic patients to prevent seizures. That's the whole kit and caboodle. That's why we give it, 100%, to help prevent seizures. A woman whose BMI is 29, is that too high or too low?
Too high.
Too high. The normal BMI is what? 17
to
27, so it's high. So that means she should gain how much weight during her pregnancy?
B.
B is the number. You go back and look at your numbers. B, 15 to 25 pounds is the recommended weight gain. Okay, number 12. The nurse is caring for a woman who has been diagnosed. She's been diagnosed with severe preeclampsia. Which finding warrants further assessment? Now, again, those of you guys in clinical yesterday, some of you had this question, so don't blurt it out for everybody else. This is a hard question. This is a critical thinking question for sure. Ready about that one? Let's move on to number 13. Diagnosing preeclampsia in the pregnant patient requires that which criteria be met? Select all that apply. So, which criteria are appropriate for diagnosing preeclampsia? Okay. So number 12. Those of you guys who know, don't say it. For the rest of you, what do you think the right answer is?
C.
Yeah, you got it. Nobody ever gets that right. Yay! Pat on the back. So why did you pick C? So tell me why you picked C.
Because it's new.
That's it. Because that's the most important thing is anytime you have a new symptom that you have not seen before, that should be ding, ding, ding. I don't know what that means. Is it, it may be worrisome, it may be not, but you must assess it. So let's look at the other choices. MAG level of 5.8. What do we want the MAG level to be with somebody on MAG sulfate for preeclampsia?
4 to 6.
4 to 6. So is that therapeutic? So it's okay, right? We're not concerned about that. Patient feels warm and flushed. What does MAG sulfate make you feel like? Hot, warm, and flushed. So is that unusual? That's an expected finding. When they're on MAG sulfate, they turn it up. I can't take it. I'm so hot. So that's normal. Deep tendon reflexes are 3+. That is brisk. That is concerning. But the question tells you the patient has severe preeclampsia. So do you expect to see brisk reflexes in a patient with severe preeclampsia? Isn't that an expected finding? Yeah. in a patient with severe preeclampsia. So make sure that you let the question give you what it'll give you. If there's something in the question, it's usually there for a reason. That word severe there is to tell you that those dictation and reflexes are expected in a patient with severe preeclampsia. New onset of cough could mean several different things. Number one is the answer because it says new onset. Anytime you see a question that says new onset, you better think long and hard before you don't choose that. Because that's something new you haven't seen before. The other part of it is, how's mag sulfate excreted? Where's it excreted from?
Urine.
The kidneys, right? The urine. If we don't excrete it and it starts to build up in the body, you see what kind of problems as a result of that. Not for mag sulfate toxicity, what happens to your patient with mag toxicity? Respiratory issues. Respirations drop. They may also get pulmonary edema. They're on bed rest from mag sulfate. They could get pneumonia from immobility. All respiratory stuff. So you got a respiratory symptom in a patient who's apt to have respiratory issues, and you also have a new onset. So it's kind of a double whammy. It's right for both those reasons. That was a HESI question. It's a really hard question, but it's a great question. Because you really have to think. You have to think through each one of those and think, is that okay? Is that okay? Is that okay? So kudos to those of you who got it right. All right, number 13. Which of these are appropriate for diagnosing preeclampsia? How about A? What? A? What'd you say? A, B, C. Now, the reason I took this question out is because technically speaking, it's twice within 6 hours, but is 6 hours in 1 day? Yes. I mean, so I really can't count that wrong. But technically the rule is blood pressure 140/90 twice in a 6 hour period. But 6 hours is in 1 day. So, yeah, that's why you didn't choose it. That's why I took it out, because I would have had to count it right either way. Yeah. So technically speaking, you're right. So I took it out because of that. I could have just changed it to 6 hours if I wanted to, but so whether you pick B or not, that you're okay. Technically, like I said, hair splitting, you almost have to say not right because it's 6 hours, not 1 day. All right, number 14. I know this is a nutrition book. That's okay. Which of the following correctly describe the caloric needs of a woman during pregnancy? Select all that apply.
B and C.
I'm just reading it to make sure. That is correct. B and C. Caloric needs do not change. That is not true. Caloric needs do change. Increase by 850. No, that is not true. They are higher in lactating woman, and they increase by about 400 calories a day during pregnancy. B and C are correct. All right. Let's do these two. All right. Which statement is most accurate in describing what the nurse should be aware